The next speaker that I'm going to introduce is Dr. Aboulhosn. He is the director of our Amundsen Heart Foundation, and he is going to talk on heart failure and mechanisms and its mechanisms in adult congenital heart disease. Jamil.
Great. Thank you for having me. And all right. So I just push next. That should be it. I just want to recognize Dr. John Child, who is the former director of the Adult Congenital Heart Disease Center, the Amundsen UCLA Adult Congenital Heart Disease Center here at UCLA, who's here with us today. And if it weren't for Dr. Child, I wouldn't be here, Dr. Reardon wouldn't be here, and frankly, our program would not be where it is. And next to him is Pam Miner, who is a nurse practitioner at the center and supervises the practice in many ways, and she's been there from really the get-go since Dr. Perloff was the director of the center, and we wouldn't be here without Pam Miner or Linda Hauser, who's also over there, who's the other nurse practitioner at the center. So these are the people that essentially do all the work. We wouldn't be here without them. So I'm going to talk about how we define and monitor heart failure in adult congenital patients. I'm going to start with essentially reiterating in some ways what Dr. Reardon said, but showing some data here. This is from Circulation 2007, manuscript by Ariane Morelli, who's actually a former graduate of our program here at UCLA, who runs the Adult Congenital Heart Center at McGill at this point. And this is data from Quebec between 1985 and 2000, essentially showing the growing number of young adults and middle-aged adults with congenital heart disease, a doubling of those numbers for most of these age groups. And frankly, if this data was looked at again now in 2013, almost certainly you would see an increase in the number of older adults with congenital heart disease. A little bit of a historical perspective. Again, Dr. Reardon touched on this. Survival into adulthood is now the norm for most forms of congenital heart disease, including cyanotic, single ventricle physiology. Really, pulmonary venous atresia is probably the one condition where this does not apply. I should point out that this 5% growth per year, these survival numbers that we're talking about, this is true for the Western world, for the developed world. This is not true for much of the world, though. So most of the world's population does not benefit from many of these advances. Sub-Saharan Africa, Southeastern Asia, and we should just keep that in mind. Let's talk a little bit about heart failure mechanisms in congenital heart disease. I tried to put this simple schematic forward here, essentially talking about volume overload versus pressure overload lesions and their downstream results. And we often have a combination of volume and pressure overload. Somebody who may have a shunt, as well as a good example would be somebody with an atrial septal defect who also has pulmonary valve stenosis or has a patent ductus arteriosus and a bicuspid aortic valve. Volume overload generally results in chamber dilation, in systolic and diastolic dyssynchrony, progressive heart failure if not corrected, and if the volume overload is significant, abnormal, relaxation, restrictive physiology, fibrosis and scar formation, an increase in arrhythmia risk, elevations in BNP levels, dyspnea on exertion, progressive atrioventricular valve regurgitation. Pressure overload, on the other hand, has some similarities, but generally results in more hypertrophy than chamber dilation, but also will have many of the same downstream effects, such as progressive heart failure symptoms, chamber stiffening, dyspnea on exertion, elevations in these natriuretic peptide levels. Some of the late heart failure issues in operated adult congenital patients, I think this is a slide that I pirated from Dr. Child from one of his talks. When he retired, he gave me all of his talks. So, John, this might seem familiar to you. So prolonged cyanosis. What is cyanosis? If you have an oxygen saturation level, systemic oxygen saturation level less than 90%, then you are cyanotic. That can have various effects on patients, and we'll go over some of those, but that needs to be taken into consideration, living essentially with a much lower oxygen saturation than other human beings. There are certain adaptive mechanisms for this, such as increased red blood cell levels, but almost all of these patients have a reduction in exercise capacity and functional capacity, and they're at increased risk for stroke and hyperviscosity symptoms and such. How about prolonged pressure overload, such as aortic stenosis, subaortic stenosis? Well, that will cause chamber hypertrophy, and over time, the compensatory mechanisms that the heart develops to deal with pressure overload may fail. And that's when patients become symptomatic and require an intervention, as opposed to just using absolute number cutoffs, like a gradient over 40 millimeters mercury means you have to intervene. Well, sometimes that's not really the case. Prolonged volume overload. People who received shunts as children, or people who had ASDs or VSDs that were not closed in a timely manner, the long-term effects of that. Poor myocardial intraoperative preservation. Obviously, that's not a case now. Dr. Ardahali, you guys do a great job. Dr. Binwali, but we have to deal with patients who may have been operated on in the 1950s, 1960s, in the early days of cardiopulmonary bypass, who may not have had the same degree of cardiopulmonary protection that people are given now. And how does that affect function long term? And I'll show you some data on that. People who have had patches put into the heart, somebody who had a large ventricular septal defect, and somebody took pericardium and patched that. Well, we get these people transferred in saying, oh my goodness, they have terrible heart failure, their ejection fraction is 20%, their heart is not working. Well, sometimes, you have to not look at the patch and look at the rest of the heart. If the rest of the heart's working okay, then that's that patient's baseline function. So you have to consider that. Large incisions and scars that are left in place. There is no curative procedure when it comes to congenital heart disease, other than, and we've sort of argued back and forth about this, possibly closing a tiny patent ductus arteriosus. But if you have to open up the heart or you have to leave something in the heart, you are going to leave a scar behind. And that is going to increase your risk long-term for developing arrhythmias, macro-reentrant arrhythmias. And we'll talk about that. Residual valvular disease, or shunts. Just because somebody fixed something, it doesn't mean that it's not going to leak long-term, or it's not going to open up again. So, I would, and again, this is now happened, but we have a lot of patients who in decades past were told by their pediatric cardiologists or their surgeons that you're cured, we fixed you. And then they're shocked when in their 20s they end up in an emergency room with an atrial arrhythmia. And somebody goes, oh, no, you're not quite fixed. You need another valve surgery. I need to do this. You go, well, hold on a second. What was I misled? I think that nowadays there's a recognition out there that we don't really have curative procedures, and we got to keep that in mind and understand that these people need lifelong care. I cannot reinforce what Dr. Reardon had to say enough. We lose them in that sensitive adolescent, post-adolescent period. The way they come back into care is they come back into an emergency room, and they come back really sick, and they have a far worse outcome, and they will cost the medical system and you as the taxpayer much more money than if we were just smart and transitioned people appropriately. So can't reiterate that enough. Arrhythmias, we'll touch base on that. Conduction defect or pacemaker rhythms. People who have had scars put into their heart and are not going to have normal conduction. Even if they don't have arrhythmias, they're going to be at an increased risk for having heart block, sick sinus syndrome, requiring pacemakers. Or if they had a pacemaker put in when they were 14 and then they were lost to care, what happens when that battery runs out? So all things that should be considered. Then you also have to consider superimposed adult disorders that may cause ventricular dysfunction. If they acquire valvular lesions like aortic stenosis or aortic regurgitation, if they develop systemic hypertension, okay, as we age, most Americans, they eat too much salt, they have a propensity for developing hypertension. What happens when the patient with single ventricle physiology develops systemic hypertension? That's an added lesion that they didn't have at birth or in early childhood. Coronary disease as they age, diabetes, Very, very important. I'll show you some of our own data on Tetralogy of Fallot and what sort of risk factor diabetes and systemic hypertension are for arrhythmias in this population. Pregnancy. What are the effects of pregnancy on these patients? The patient that Dr. Reardon was presenting. So, you know, let's say she goes through the surgery. She does great. Okay, we do the arrhythmia surgery, we do the extracardiac Fontan, she comes out of it, her ventricular function is preserved, we put her on a treadmill 6 months later, she does pretty well on the treadmill, no concerning arrhythmias. Is she free to just go ahead and get pregnant? Well, you know, obviously it's her own choice, but she remains a high-risk pregnancy. So then you have to manage her through the pregnancy and realize that in a few % of these patients, they will develop ventricular dysfunction during pregnancy that will not get better after delivery. So pregnancy portends not just a short-term risk, but a potential long-term risk that we're just becoming aware of. Endocarditis. This is another problem that brings people in to the hospital who have been lost to care. The young patient with a bicuspid aortic valve who doesn't take antibiotics when they get dental cleaning, for example, and comes in with infective endocarditis. So it's diligent education generally prevents a lot of these episodes, but something to keep in mind. And then chronic respiratory diseases. The Fontan who is a smoker that develops emphysema. Okay, so we have to think about that as our population ages. So this is a diagram that I did of the various congenital shunts that we deal with. And these are shunts that cause volume overload, in some cases are associated with pressure overload, starting all the way at the superior vena cava with superior sinus venosus ASDs and going down through the inner atrial septum. The hole can be in all of these places, and sometimes you'll have combinations thereof. Then crossing the tricuspid valve to the ventricular septum, from inlet VSDs to muscular VSDs, to perimembranous and membranous VSDs and supracrystal VSDs, and then patent ductus arteriosus. So that's kind of running the gamut for most of the shunts that we deal with. Not all of them, but most of them. Unrepaired atrial septal defects. People often say, oh, this patient has Eisenmengers because of an ASD. And that's actually a misnomer. Most atrial septal defects will not cause severe pulmonary hypertension. And pulmonary hypertension typically develops later in life. And what we're looking at here is the increase in the presence of pulmonary hypertension in this population to, let's say, about 50% at 50, 55 years of age. So if you are 25 years old and you're blue and you have a 1.5 centimeter ASD and you have severe pulmonary hypertension, it's not just the ASD that's causing that. You probably have some predisposition to developing pulmonary hypertension anyway. What is the Eisenmenger syndrome? Well, the Eisenmenger syndrome is essentially a large, unrepaired intracardiac shunt, and we like to say a central shunt or a post-tricuspid valve shunt. A shunt at the ventricular septal level or at the great arterial level. These patients from the get-go, unless they have some sort of obstruction to flow to the lungs, will have pulmonary hypertension, okay? The RV and the LV in this example, which is the classic Eisenmenger complex that you see here in this diagram, is essentially a large door between the right and the left ventricle. So the right ventricle will see systemic pressures from the get-go. The pulmonary arterial resistance is much lower in infancy than the systemic arterial resistance, and so you'll have a big left to right shunt early on in life and probably for a few years. And if you survive that period without dying from congestive heart failure or arrhythmias or pneumonias, then you will go on to develop the Eisenmenger syndrome. Your pulmonary arterial resistance will rise. This is in the vast majority of patients, not all of them. Will rise and eventually will equal and surpass the systemic arterial resistance, reverse the shunt, and the patient turns blue. What are the complications of Eisenmenger syndrome? All sorts of things: arrhythmias, hemoptysis, pulmonary infarction, pulmonary artery rupture, the complications of chronic cyanosis, which is a multi-system disorder, Pulmonary vasodilator treatments were initially thought to not be effective in this population, but are actually quite effective. The usual surgical options do not really apply for this population. If you try to close that hole in the heart once they've developed this degree of pulmonary arterial disease, the patient generally does not tolerate surgical intervention. But we are approaching a new era now of, with powerful pulmonary vasodilators, with less invasive techniques for potentially closing holes, for leaving fenestrations in place, where I think this dogma is being questioned, and we're trying to question it ourselves. But transplantation is generally the accepted option if these patients are failing. Chronic right ventricular adaptation. So patients who develop idiopathic or other forms of pulmonary hypertension later in life typically have a thin-walled right ventricle that's a volume pump, like most of us do in this room. And that right ventricle is less able to take care of the pressure overload than a ventricle that's been exposed to high pressure from the get-go. So what we have here are two examples. The top one is somebody with HTN, which is primary pulmonary hypertension, now known as idiopathic pulmonary hypertension. And notice how large the right ventricle is, how dysynchronous that septum is in end systole, how it's moving over into the left ventricle, versus in the lower panel, a patient with Eisenmenger syndrome, who has a thicker right ventricle, better systolic function, and better cardiac geometry. And the survival curves for these two patient populations are very different. 50% of patients with Eisenmenger syndrome are alive in their 50s. So, whereas if you take patients with idiopathic pulmonary hypertension, without aggressive treatment, the vast majority will be dead in 10 years. So, in the end, it's not about the pulmonary hypertension, it's about the cardiac output, and it's about the right ventricle. And this schematic shows this nicely, in that people get excited when they give people therapies and they go, oh, the pulmonary artery pressure is lower. Well, okay, but the patient's huffing and puffing, their neck veins are up to here, their belly is bloated, they have ascites, they're in chronic heart failure, and their cardiac output is low. So no, that's not a good thing, that's decompensated heart failure and pulmonary hypertension. So the real key is in the pulmonary arterial resistance and in the cardiac output. This is a paper out of our group. Dr. Reardon was the primary author on this, published in AJC last year, looking at BNP as a prognostic marker in patients with Eisenmenger syndrome, and looking at heart failure, hospitalizations, or death in these patients. And a BNP cutoff of about 140 generally gives you a good splay there. And we tend to be much more concerned about our patients who have higher BNPs. That's a marker of a ventricle that is not tolerating the chronic pressure overload. Tetralogy of Fallot, this is the most common. What, 5 minutes? All right, I'll try to rush through it here. While explaining Tetralogy of Fallot. So anyway, it's a big hole in the heart, an obstruction to pulmonary flow, either pulmonary stenosis, subpulmonary stenosis, or supravalvular pulmonary stenosis. And it's the most common cyanotic congenital defect. You have various forms. Some patients are bluer than others. Some patients require intervention in infancy. Some do not require intervention until later in life. Without some sort of operative intervention, those that are cyanotic will generally not survive to adulthood. But in this day and age, most of them do in the Western world because of the surgical interventions that we have. Numerous surgical palliations for Tetralogy of Fallot. This is from a chapter that Dr. Child and I wrote in Hearst the Heart, a schematic of the various surgical shunts. It's in your handout, so you can kind of take a leisurely look at it on your own time. But the culmination is at the bottom, some sort of valved communication between the right ventricle and the pulmonary artery, and closure of the ventricular septal defect. Pulmonary regurgitation is a chronic, long-term problem in these patients, and it needs to be appropriately identified. Echocardiography is a cheap and user-friendly way of doing this. It's available in most practices, and if you look at this reference here from the American Society of Echocardiography Journal from 2010, it'll tell you how to do it in your practice. If you identify severe PR, please send that patient our way, so we can help them. And this gives you an algorithm for how we can go ahead and do this. Can I keep going, or?
We're gonna have to wind down.
All right, let me wind it down with numerous issues in Tetralogy of Fallot, from arrhythmias to heart failure to valve dysfunction. Arrhythmias are a real plague. I was actually not here this morning because I was in the emergency room because one of our patients with Tetralogy of Fallot came into the ER in poorly hemodynamically tolerated arrhythmia, in atrial flutter, reentrant atrial tachycardia. So this is a huge issue for us, and we collaborate very closely with the surgeons and with the electrophysiologists to provide good care for these patients and try to suppress their arrhythmias as much as possible, but this is what people die of. What are the arrhythmia prevalences? About 30% of adult tetralogy patients will have an atrial arrhythmia. About 15% will have a ventricular arrhythmia. All of these increase with age. And again, nothing against surgical approaches, but the more surgeries you have, the more likely you are to have ventricular tachycardia as well as atrial tachycardia in this population. So it's very smart for us to be judicious about when we send patients to the operating room, and the rise in transcatheter interventional techniques for palliation of some of these conditions, I think, is merited given the issues with numerous surgical interventions in this population. But overall, these patients do pretty well, and if they're transitioned appropriately and they're cared for appropriately, most of them will survive and have very productive, happy, and healthy, long lives. So thank you very much, and I'll stop there.
Thank you, Jamil.